Good. Hi, everyone. So good morning, good afternoon, good evening. My name is Cash, and I'm the Behavioral Science Global Lead at UNICEF. Oops, sorry. Oh, sorry. That's a good start. Cool. So let me start again. So hi, my name is Cash, and I'm the Behavioral Science Global Lead at UNICEF. Thanks for joining us today for our session, exploring some examples of the wonderful work our colleagues in country offices have been doing in applying behavioral science to solve a range of issues across the different sectors, from nutrition to health. So here at UNICEF, our application of behavioral science can generally be categorized as 3 work streams, which is institutional integration and capacity building. So more of the internal work, how we can improve our own operations, how we can change cultures, and also capacity building to help build behavioral science capacity across the organization. And then we have strategic and technical leadership. So a lot of the work that we do with our government counterparts, so building behavioral science unit, providing them technical support on addressing their own issues and agenda. And then finally, research and innovation. And so that's mostly what we'll be looking at today, with some excellent examples from our different country offices to talk about some of the research and application that they've been doing to address various social policy issues. So without further ado, I'd like to pass it on to my colleagues. Arupa, would you like to go first?
Hi, Cash. Thank you so much. I am the Social and Behavior Change Specialist in Türkiye Country Office, and I would like to share with you our little experiment with motivational interviewing technique. Let me share my screen. Let me know when you can see it.
Can you try that again? I think I saw something pop up, but then it disappeared. Ah, here it is. Yep. It's not on your PowerPoint slide. It's on your
One
Teams.
second. Yeah, just
yeah, no worries. Yeah, no worries. Also for audience members, if you have questions, please submit them in the Q&A. There's a Q&A button, so please put your questions there and we can answer them as we go along, and we'll also come to them at the end.
Sorry, Cash, I'm having a little bit of an issue. If you can pass on to the next person, I will just come back.
We'll come back to it, Rupa. Aga, would you care to introduce yourself and
Of course.
Thank you so much.
Thanks so much, Cash, for this introduction. Thank you for the invitation. Hello, colleagues. It's really nice to be here with you, and I'm very happy to share with you the case study of an intervention and of the research that we've done here in Poland. And actually, I also have slides, so I will try to share my screen with you. And please let me know, somebody, if you can see my screen already.
Yes.
Yes, perfect. So we can go ahead. So this case study is about vaccination, and this is, of course, a very big and a priority topic for UNICEF, as you know, and here in Poland as well, especially in the refugee context that we had. So as you know, in 2022, with the escalation of the war in Ukraine, we had a big influx of people coming to Poland to seek refuge, and mostly these were mothers with children. So imagine. And here we're taking this photo at the very, very beginning in 2022. And you can see Ina, this is a mother. And imagine being the mother in a situation when you're coming to a whole new place with a child on your hands. Everything was disrupted in your life. And now you're in a situation where everything is new for you. You have to find a kindergarten for your child. You have to find a job. You have to navigate in the new systems. And here, we're also looking at other priorities like health priorities, like immunization, like vaccination. So of course, there are so many things that you need to take care of. So imagine being in this situation and then thinking about the priorities and what is good for your child. Of course, vaccination may not be the first priority. So we as UNICEF wanted to do something to help the mothers and understand their barriers to vaccinate their children. So first, what we've done, and this was in 2022 already, we've decided to do a research study to understand a little bit better the needs and the barriers that the mothers can have with the children from Ukraine. And we've used the mixed methodologies, so the quantitative and the qualitative and the quantitative research. We started with the qualitative one because we thought it would be really important to talk with the mothers, to understand their behaviors, and to dig a little bit deeper about what are their needs. Then we decided, and I will talk a little bit more about this later, with the quantitative study, and we've done also an experiment to test the different communication. For the qualitative research, this is just, but I'm sure a lot of people who are here with us today, you know this framework. We use the behavior drivers model here with the psychology, sociological and environmental factors that influence the behavior of mothers. So first I will go quickly to the qualitative research findings. And here, as you can see, we frame them with this helpful framework. The first, the psychological factors. And I think the most important ones is that women were facing many different challenges. So this was something that I was mentioning at the very beginning. With competing priorities and this complex information about vaccination, it was really difficult for them to make vaccination decisions. As you can see, they're even saying sometimes it's just too much to figure out, right? The other is very important for us, which were the sociological factors. And here we know that being in this new situation, mothers also relied heavily on the groups, like maybe Ukrainian mothers, maybe on social media. They were looking at people who are similar to them and asking them, what are the best practices? So here, this is something that we also needed to look into very closely and maybe to find the right messengers for the communication for people who will convince them and promote the vaccination among the mothers from Ukraine in Poland. And then another one is communication environment, and that was also important for us. So I already mentioned the social media, which is a big platform for exchanging information, and the important one. But also it's important to highlight that in terms of communication environment, the mothers usually have had some problems with understanding the language. And that was the case also when we're talking about the vaccination and immunization services, because they couldn't understand the doctors, they couldn't understand the health workers. People are saying that Ukrainian and Polish languages are similar, but unfortunately when it comes to very critical decisions and vaccinating, which is a very difficult subject, it can be very challenging to understand each other. So with this, we decided to do a quantitative research because we wanted also to have some statistical analysis, but also wanted to do the randomized controlled trial with testing different communicates. And first, what we found with quantitative research is that almost 40%, and you can say 1 in 3 mothers from Ukraine, did not know how to vaccinate the children in Poland. So they did not know where to go. They did not know what are the different options for them and what are the health workers that can support them in this decision. It's a really big percentage, and this is something definitely that we needed to address. Then we asked them about the reasons for not vaccinating children, and that was a very interesting one for us because, like, as you can see in this graph, at the very top one is again, I don't know how to vaccinate my child in Poland. Maybe we were thinking, and we are always biased, that of course the information is everywhere. It's in the trusted sources. The Ministry of Health is informing about this, but of course, it was not available for people who were coming from Ukraine. They were not looking for the sources, maybe in those trusted communication, like Ministry of Health, you might say, or public health institutions. And maybe the information was not provided in the right way. So maybe it was not in their native language, right? So that was a big obstacle. The other one is, of course, the concerns about the safety. And I think it's oh, thank you for this. I can see the comment about the sample size. I forgot to mention it was 1,900, so almost 2,000 mothers Thanks. And of course about the safety. And also one more thing I want to highlight here is that I prefer to vaccinate my child when I'm back to Ukraine. And I think this is an important one for us from the behavioral lens perspective, because we can see that people even prefer to go to the country back when there is an ongoing war, because they know the system better, because it's easier for them to navigate. One more thing, and I also mentioned that, is that they were the mothers wanted health workers to spend more time maybe during the doctor's appointment, review the child's vaccine record and provide the information in their native language. That was something that appeared a lot. And one more from the quantitative study, very important finding as well, because we built also our communication around this and we leveraged this, is that the trusted institutions were official health institute and also doctors. But you can see that it's coming that other parents from Ukraine living here, so living in Poland, and social media is also a high rated and a trusted source of information. So I'm going to the experiment now, and I wanted to show you what we tested. We had actually 3 different messages that we tested within the study with the randomized control trial. And the first was leveraging the trust that we've seen right now, and it was saying that the Polish health system is very strong, has a strong immunization program. The other one was about the access. So we were saying that getting child vaccinated in Poland is very easy and convenient. And the last one was highlighting the vulnerable situation. And it was saying that the vaccinating your child now is very important. So please don't miss out on this opportunity. And the one that proved was most impactful was actually the one highlighting the vulnerable situation that the mother were in. So it was really tailored, individual to their context. It was helping them understand that even there are other priorities that they have during their stay in Poland, it is important to remember about the health issues. It is important to not to wait and delay their vaccinations, but to vaccinate the children when they are here in Poland. And I just want to end with different behavior interventions that we've done based on the research findings. Of course, we've used the different communicates, the communicate that we tested, but we've also leveraged the different findings. So, for example, the social factors, the fact that they want to be within the group, that they exchanging informations between themselves, the mothers. So we had some public events when the mothers could meet in a more informal way. Here is the picnic and the run that we've organized, and it was about vaccination, and it was promoting vaccination. It was called Trust in Vaccination. We also prepared the leaflets and the materials that were in Ukrainian because they wanted to provide information in their own language, and it was easy to understand, showing the way and the journey how to get vaccinated in Poland. We prepared something, the same thing in Polish as well, for the health workers to understand the materials. And also, of course, we've been sending the SMS messages to the mothers with the one message that proved the most impactful. And I think this is all from me today. So thank you so much. I hope you like it. And I don't know if maybe you have questions. You can also type it in the chat. Thank you.
Thank you so much, Aga. That was great. Yeah. As Aga said, please share some of your questions in the Q&A or put them in the chat. I think there's not too many of us that it won't get overwhelmed, but yeah, we can keep it as a casual discussion. Next, should we go to Amos?
Great. Just gonna share my slide in a second.
Thank you so much.
No problem.
So also, please introduce yourself. Sorry.
Yeah, I'm gonna do that as I share my slide. Just
Thank
1
you.
minute. So a very good evening to everybody online. This is evening in Cambodia. My name is Amos. I work as the social behavior change specialist for UNICEF in Cambodia. I'm going to be sharing with you our project on embedding a nudge component in our ongoing work supporting government on early childhood care and development to support growth monitoring and learning through play. Really, to start with, part of the issue we are supporting is the government is implementing the national policies and action plans on early childhood care and development. And one of the key components therein is the nurturing care parenting package that is really focusing on parenting practices, a very big compendium of list of behaviors that we are promoting. But as most of the colleagues online may know, a lot of the government package focuses a lot on information, education, communication, which is obviously a part of the package, but there is more that needs to be done in order to achieve behavior changing in behaviors and practices. So we had a challenge of going beyond information education to build a nudge component as an additional behavioral science tool that can support and complement existing government intervention. And so that's what we're going to be sharing in the next few minutes with everybody. And so to really get us started, we were asking what we call how might we questions. And obviously, these questions really give us a good starting point at ideating solutions, but also not assuming that we know the problems or the barriers, but we begin by really engaging the parents and caregivers and actual right holders in order for us to understand not just the barriers, but also the solutions. So we're asking two major how might we questions. Number one, how might we support parents and caregivers to monitor the growth of their children and seek prompt care? But also, most importantly, one of the major focus for the intervention was playful interaction. How might we regularly, support parents to regularly play with their children to enhance early stimulation and development, which is also part of the broader goal of early childhood care and development on improved cognitive, social, and also cognitive and language development for children, especially in the early years. So in order to really get this started, we didn't want to do this as a UNICEF project, but obviously government, because government is already implementing a national program on parenting. So part of it was embedding in an ongoing government program, and that necessitated really working through a capacity development approach that involved a lot of introducing the approach, training, coaching, mentorship. We had a training of government counterparts at national, subnational level, up the community level on human-centered design and behavioral insights to understand that there is more that we can use beyond information, education, communication, and there are different behavior science tools and techniques we can apply to complement what is ongoing and enable parents to adopt key parenting behaviors. So through that capacity development approach, as you're going to see in the subsequent slides, we worked with the government counterparts to do formative research, co-creation, testing, and right now we are doing implementation and monitoring. And we also worked on evaluation design with a baseline study and an upcoming endline study next year to assess the impact of our intervention and inform scale up and policy and advocacy. So we go through some of the specifics. We did formative research, again, going to parents and caregivers to understand the issues from their perspective, again, validating our assumptions, understanding barriers, facilitators, motivators, but also most importantly, trying to, mixed methods, both qualitative, but also the quantitative component where we did a baseline study on the key behaviors. Within the qualitative component, we are looking at, again, the barriers and also to generate insights. We are learning from parents, for example, that, play is played when parents play with their children don't necessarily learn, that play is different from learning, but also that parents are so busy, they don't have time to play with their children. They have to set aside time to play, and they're not necessarily integrating play in routine activities at home, but also that play makes children disrespectful and also stubborn. So it's not necessarily something that is culturally promoted or supported. We use mixed methods, in-depth interviews, focus groups, card sorting, all these methods, as you can see, to try to really understand the issue from the perspective of the parents and caregivers and work with them to ideate and generate solutions that can support the government program. So this was, again, the design sprints we worked on after all the trainings, after the coaching and mentorship with the government colleagues. Some of the participants from the training were working with us as co-facilitators through each of the steps you see and you're going to see subsequently, so that we're embedding a stronger capacity development component along the way. Again, not making them SBC experts, but whatever skills we will transfer on, that would make, again, the program better as you're looking at scaling up and sustaining the program within the government intervention. And so after working through different iterations and testing 6 different solutions that came up as really very promising and stronger, we picked one that came out really stronger within the traditional Khmer culture and context. And this is the Smart House kit. And the kit is based on the Khmer culture of the house or the home as a foundation for nurturing children who are smart and intelligent. And so the kit has colorful, vibrant displays of growth milestones. This is the chart that shows what stage the child should be at depending on their age, and so that the parent can monitor and know where their child is and seek prompt care where there is need. But most importantly, the kit has nudge cards. These are different hanging cards that are positioned strategically in different locations of the house, in the kitchen, in the dining area, in the compound, in the bedroom, different places in the house where the parents and caregivers can see to nudge playful interaction and engagement with their children, as part of routine activities in a home. And again, the goal is obviously, again, to promote playful interaction, growth monitoring, and learning through play. So through iteration and implementation and monitoring, we refined the kit, made it even so much better based on what we were learning from the users over time. Again, continue to train government teams, especially the community level facilitators, on correct use, correct dissemination, user feedback, again, to support the implementation. We produced 20,000 copies that were disseminated to specific households in the target provinces. We're working on ongoing monitoring and tracking of the tool and metrics around availability, usage, ability to nudge or not, and how that's going to inform the impact evaluation. We're also doing regular check-ins on the households that received the kit on how they are using it, and again, getting feedback on the same. But as part of the intervention, again, through the whole process, we designed an evaluation design that has 3 different groups. One group has the government nurturing care parenting class, which is basically the parenting class on its own as an intervention. The second group has the combined government nurturing care parenting class with the behavior nudge component. And the third group is the comparison control group, where none of these interventions are happening. And obviously, the goal is to compare changes in outcomes over time across the treatment and control groups, to be able to ascertain the impact of the intervention on parenting practices that are being promoted. And with a lot of lessons we are learning, and we can discuss back and forth into this. We've designed this project intervention building on the COVID-19 momentum and lessons, where, again, the government had really embraced a lot of science-based approaches on data use to support the risk communication and community engagement work that UNICEF really pioneered and supported a lot. And we are trying to go beyond the health sector to go into education and early child development program that traditionally have not embraced a lot of these SBC approaches before. And so this was an opportunity for us to do this. And there was a lot of buy-in and excitement really for the government teams to embrace these new approaches. And really, since we started the program, there's a lot of interest and participation in implementing the program. And also the whole idea of embedding a stronger capacity development component, finding government where it is, our government counterparts, not just starting a project on our own as UNICEF, but finding them where they are, an existing government program that is ongoing, embedding an nudge component, and working with the government to design, obviously monitor and implement together and learn together. And as we're planning the evaluation as well, we're also looking at evaluating together to generate lessons for scaling the program in the next years. So yeah, we'll stop here for now. We'll go back and forth in the discussion where colleagues are more interested. Thank you.
Thank you so much, Amos. That was amazing. Yeah, this will be very exciting to find out what the results are once you are able to collect the baseline, the end line, sorry. Next, we go to Turkey. Arupa, is your system working now?
Yes, let me share my screen.
Perfect. Thank you very much.
Let me know if you can see it.
Yes, but it's still on your Teams page. Now it's on your emails. Now it's on your desktop.
It has stopped.
No, it's still there. But we couldn't see your actual PowerPoint slides. Is it on a different page? Something's coming. Nope, it's gone.
Sure. Okay. Maybe go ahead with Faisal. I think this will require some help. Thank you.
Okay, maybe we can go back to your laptop instead. Okay, cool. Faisal, would you like to come in? So Faisal was part of the Pakistan country office, but he's now moved on to another position, but I'll let him introduce himself. Thank you so much, Faisal.
Thank you, Gash. So, yes, I used to be the behavioral scientist at the Pakistan country office, and I'm currently a research fellow and associate member at the Faculty of Theology and Religion in Oxford, where I do incidentally lead, co-lead a UNICEF Oxford research partnership on religion and child marriage. So my engagement with UNICEF has not sort of ended with my role in UNICEF. So the claim I'm sort of seeking to make today is, and I'm going to support it with one example, and if I have time, another example too, is that human cognitive capacities constitute multiple environmental specific suites of skills that have evolved to navigate the institutional worlds humans themselves construct. So it is therefore a serious analytical error, I'm arguing, to presume that the very abilities now optimized for current institutional demands are either deficient or universally transferable for different contexts, will always favor different constellations of cognition. So what that means essentially is that we often think of parents, for example, not accepting vaccines for their children as something that is a deficiency within their cognitive capacities, or we talk about their knowledge, attitudes, or behaviors generally. And my argument is that actually that is not the case, that instead of looking at a deficiency view, we should be taking a more constitutive view in which environment-specific suites of skills are developed within communities. So I call these cognitive phenotypes. So these are sort of population level patterns of attention, memory, perception, decision-making that emerge when groups of people repeatedly solve problems in the same ecological institutional niche. And that institutional niche is not necessarily the one that were offered by the state or by development programming. And it's a default that they experience in their everyday lives that we often try to understand but are unable to really capture in our research. And my argument is that we need to, based on my claim, my argument is that we need to push towards understanding that ecological institutional niche to capture these cognitive phenotypes. And of course, recognizing their systemic origins would allow researchers and policymakers both to respect existing adaptive skills and to design interventions that modify them but in ways that don't pathologize the local cognition of these people, which is very important. So for example, one of the things that we often do is and I'm sure everyone is familiar with the think fast, think slow, or type 1, type 2 processes, cognitive processes. Type 1 is the sort of more rapid, intuitive way of engaging with something cognitively, and type 2 is the more sort of deliberative, slower process. Often what we do is, and this is something very important and applies to UNICEF programming as much as it does to government programming in Pakistan and elsewhere, is that we try to target slow thinking, but we expect fast changes from them. And the real problem is that we need to solve fast thinking or change fast thinking, and that process is actually quite slow, and that may take a much longer period of time. And so we need to sort of clarify to ourselves that the focus that we have cognitively anyway is often on these more deliberative, slower processes as opposed to these more rapid and intuitive ones. And these are critical to these cognitive phenotypes that I'm talking about, these patterns of attention, memory, perception, decision-making, which are wholly embedded within their ecological institutional niche. So I'm going to take one example from the Oxford research that we've done on child marriage and religion. So just to give some context, UNICEF Pakistan Country Office in collaboration with the Child Protection Section and the Social Behavior Change Section partnered with the University of Oxford to understand this confounding relationship between religion and child marriage. And of course, we've uncovered a lot of problems and challenges, but also a lot of solutions, which I don't have the time to look at here. But one of the things that we looked at and tested was that parents who arrange underage marriages the assumption was that they're acting with deficient minds. Instead, what we found was that they are drawing on a locally adaptive cognitive suite that evolved under at least two pressures. The first, the fast one, was this protection first heuristic that tuned to an environment where state guardianship is very weak. And the second one is where chronic cognitive scarcity created by overlapping health, education, honor demands drain the bandwidth needed for long-term planning. So often, for example, parents talked about pubescent matches as the safest option, but parents calling these matches as lucky, signaling that their intuitive repertoire contains no ready script for waiting until 18. So there is a sort of a scarcity for long-term planning. And most interventions ignore this dual architecture. So fast automatic versus slow deliberative, and the scarcity that pushes parents towards these immediate fixes, they often then are not addressed, and these interventions misfire. So if we were to, for example, look at child marriage and reframe that within the context of within this context-specific cognition and dual process, we would see child marriage often, and this is particularly true of areas where feudal systems are far more embedded. We see there that there is this environmentally shaped protection suite. In rural districts where formal policing and child protection institutions are weak, parents rely on locally adaptive cognitive packages like quick threat detection, honor risk calculation, the intuitive equation of marriage with safety. And these are very functional for their institution world, not a deficiency to be corrected. We would want to correct it, but that would require sort of a long-term change that would change the way they actually think fast. So the fast thinking is skewed for basically a risk-saturated system in which they're worried that their daughters may be married to these feudal lords or may be abducted or sexually abused by them or raped by them. And so this is a genuine concern that the state has not been able to address. And so they rely on these quick heuristics. And as I said, they then implement these and often label label any match that is an early marriage in our books as a lucky outcome. And we saw the word lucky being used sort of in its local vernacular in various regions, stretching from Balochistan to Sindh to Punjab. So this was a homogeneous description of how they see marriage, child marriage in particular. And so we have this sort of type 2 process, of course. The state is attempting to raise the legal age of marriage to appeal to slow deliberative reasoning about rights and long-term health. And that is exactly what they do. But they seldom alter the sort of environment itself or the system itself that keeps the protection suite active. So for example, one of the things that elicited this sort of protection mechanism within parents to marry off their daughters early was this absence of the Qazi system. The Qazi system essentially offered local protection to families against these feudal mechanisms that were dangerous or would co-opt their younger generations, particularly the girl child. And so they would signal danger and they would protect them. But unfortunately, in the post-colonial context of Pakistan, that's not the case. So what do we need to do for that? We need to look at the core solution that retunes cues, but also not just minds. So the idea is to really try to change the institutional and environmental niche so that people actually start thinking fast differently eventually. So for example, we should revitalize the Qazi system that was there in the pre-colonial, in the colonial sort of context of South Asia. And of course, we need to, for example, engage in scholar-led reinterpretations, grassroots movements that sort of alter the way parents for fast heuristics point to child marriage. So this is one example. I know I'm sort of loading up a lot of information here. But one more example I just wanted to give was, and I know I have about 2 minutes left, is around the research that I undertook with my team on the low uptake of community health and nutrition services. So caregivers who often skip or abandon community health and nutrition services, there is low uptake, or they're sort of described as irrational. But what we found was, and this was the result of a long piece of field research, but also then subsequent reflection, is that they are relying on, again, local cognitive suites forged under cognitive scarcity. And so parents are unable to really think harder to, use these services. These services often actually burden them with a lot of intervention noise. They actually add to their cognitive burden. So with them being already sort of maxed out, if you will, or starved, if you will, cognitively, for them to use anything good or bad is actually a significant burden. And it doesn't allow them to use their existing heuristics. So what we need to, as I've been making the case, is that we need to actually change those heuristics or that fast thinking as much as possible. What that requires is something that we can discuss, of course. One thing that I just want to sort of reflect on, one of the solutions that we gave was that we give the fast thinking, whatever that is in that situation, a clear target. So bundle health, nutrition, hygiene, not into a sort of a bundle of services, but into a single experience where children of the same age in one home or are able to experience these services without knowing that they're actually accessing these different services. And the same for the parents who are, of course, responsible for these children. There are, of course, other ways of supporting this fast thinking towards a sort of specific target of using these services. And that includes, for example, SMS IVR and other forms of planning prompts and other forms of digital engagements that would allow parents to remember or to decide or to think more quickly, but toward in a specific direction, so directionally, to get their children these access to these services. Of course, we would want to build scaffolds for slow thinking. And that's something that we often do anyway. So we create these low friction tools. For example, we have campaigns and all of these other things. But I think the focus should be on really trying to re-engineer fast thinking and recognizing that it requires a long-term process. I'll conclude by just saying one thing, and that's sort of a theme that I've been sort of raising with my colleagues in UNICEF and elsewhere as well, is that behavioral science is often used for, or has become this, this sort of instrument that is introduced to evade state functions or large changes that would change how people think fast. And often we only focus on changing how people think slow. What I'm essentially saying is that behavioral science can easily become a way of evading state level responsibility or program level responsibility and devolving a lot of that to the individual itself. And that has, of course, libertarian presentations. We see that in the nudge sort of regime, of course, which we know from literature is not as effective as it was once thought of. But that itself emerged within a context where there was not much of an interest in investing in people's lives through the state. And Pakistan, I will conclude, is one of those countries where the political economy is such that the government is actually not only not interested in investing in people, but actually with its rentier class, it takes advantage of that lack of investment. So I'll close there, and I hope we can discuss this in the Q&A. Thank you.
Thank you so much, Faisal. That was fascinating. Definitely. So we've solved the issue with Arupa's presentation. So I'm going to present on behalf of Arupa. Arupa, you ready?
Yes, thanks so much, Kash. And my apologies, colleagues, for this delayed kind of technical glitch. So basically, I'll be talking to you about motivational interviewing technique to improve IYCF practices in the humanitarian setting. And maybe you can move to the next slide. So to give a little bit of context, in 2023, Türkiye experienced 2 devastating earthquakes, and it affected almost 11 provinces with about 15 million population. People who were directly impacted were about 9 million. The constraint posed by the living condition and the elevated stress and trauma, it clearly highlighted and presented 2 significant challenges. One is with breastfeeding problems, and second was the perceived insufficient milk. And this was also then corroborated by the International Breastfeeding Journal later on. If you move to the next slide, please. To address this, we used motivational interviewing technique. Let me just clarify a little bit as to why we did this. One is that clearly this is an evidence-based, people-centered approach. It takes about only 15 minutes to kind of, make it effective. It has been widely used in public health promotion, and it adopts a trauma-informed strategy. It has also been proven that when multiple exposure increases, the likelihood of behavior change to happen also increases. As part of the process, we looked at the global IYCF counseling card and adapted that to the Türkiye humanitarian context. We also ensured, so the earthquake happened in February, and this was being done in July. So the IYCF counselors were trained in motivational interviewing technique in July. Next slide. So using a case control approach, the participants were divided into 2 groups, a treatment group and a control group. The treatment group was located in Malatya, the MBC, which is the mother-baby corner, in our city, with 31 women who were receiving the IYCF counseling along with the MI technique. The control group was the Kamamarash informal settlement, where 27 women were receiving the regular IYCF counseling. Each of the women who were participating, which is almost 58 women, they've received 6 individual counseling sessions over a period of 6 weeks. The 2 evaluation methods that we used, one was to look at self-efficacy for breastfeeding and feeding healthy diets to children, and second was readiness to change. On the evaluation method 2, we looked at focus group discussions with MI-trained IYCF counselors. Next slide, please. So the key findings clearly revealed that following the intervention, the confidence level in breastfeeding improved by 25% for those who received the MI techniques. Similarly, when you look at the confidence for feeding a healthy diet to young children, again increased by 35% among the intervention group. So MI was clearly, in comparison to the control group, 3 to 4 times more effective than the standard IYCF counseling. Next slide, please. We see a similar trend in the importance of the behavior. So there was a 17% increase among the intervention group when we looked at the importance of the behavior that they wanted to change. While the readiness to change the behavior showed a significant jump of 45%. Again, the MI approach was twice as effective in the enhancing the readiness to change within the intervention group. The next slide, please. We also looked at motivation, and there was a 30% increase among the intervention group. While for the certainty of commitment, there was a 29% women who demonstrated marked increase in comparison to the control group. This is, again, a very significant kind of impact that we saw within the control and the intervention group. Next slide, please. So when we did the second part of the evaluation, which was the FGD with the counselors who had undergone the MI training, clearly the feedback that came through showed that the counselors were overwhelmingly positive about the MI inputs. They reported that the MI facilitated the development of a better rapport and trust with the women. They also made the women feel heard and valued, which was a significant component as an outcome from this entire process. Counselors also noted that the changes occurred more rapidly, whereby positive shifts were visible within the second and third counseling session. So they also kind of, reported that the 4 sessions were sufficient for most women when it came to MI using. The counselors expressed a strong sense of pride and encouragement in witnessing these positive outcomes. Next slide, please. So while I do acknowledge that this was a very small sample-based study, and the whole idea was only to test the proof of concept, whereby we wanted to essentially explore that whether the use of MI technique would potentially help improve IYCF practice in a humanitarian context, especially using the IYCF counseling cards. And also the fact that this was completely focused on nutritional outcomes. But since then, there has been a huge amount of shift, because in 2023, this was mainstreamed within the Ministry of Health IYCF training for more than 70,000 counselors and ECD outreach workers. Also in 2024 onwards, we have been able to include it as part of the immunization program, where to address the vaccine hesitancy, more than 130 health professionals and educators have been skilled. So these have been clearly some of the very important outcomes of the entire initiative. And we do believe that this kind of nimble trial has helped us to kind of look at the behavioral outcomes for nutrition, but at the same time demonstrate some very clear change at the level of self-efficacy and readiness to change. We do intend to continue with similar kind of initiatives in different sectoral programs to ensure that whether we can expand the use of MI in different fields. And that's something that we are working on and would be happy to kind of share when we learn more. Thank you. And I'll stop here and maybe leave it for any questions to be raised. Thank you so much.
Thank you, Rupa. That was really interesting. We've got 9 minutes left for questions. If anybody has any immediate questions, feel free to jump in. Oh, here we go. From Natalie. It's for you, Arupa. In terms of readiness to change, were there any differences in results depending on the behavior? So breastfeeding versus complementary feeding. And can the MI modified IYCF counseling cards used in Turkey be shared?
Sorry. So yes, we did see, especially if you can share that particular slide on readiness to change, you will see when it comes to, there were basically two behaviors we were looking at. One was breastfeeding and second was on the healthy diets for young children under 5. And we did see in the control group where there was a almost insignificant, I would say, but there was a little drop, but it wasn't really significant. But in terms of in the intervention group, we did see a huge jump in terms of both breastfeeding as well as the healthy diets for young children. And that clearly kind of showed the intention and the information which probably, if the parents or mothers are helped with in terms of preparing, then would have a huge impact in terms of their practices.
Thank you. Any other questions? If not, I will ask my own. Okay. So one thing that's always interesting is how we then communicate these results to government to get them to take it on. Arupa, Aga, since the two of you have results, like how did you then share these results with the government? Did they value the methodology used, or yeah, what was your take on how they perceive the evidence? I'm going to put Aga on the spot to answer this.
Okay. yes, but I wanted actually to take this one. Thanks so much, Kash. And this is a very interesting one. And I think it was challenging for us a little bit because in our context, you need to understand that UNICEF's presence is actually, we started in 2022, as I mentioned, at the escalation of the war. So all of the relationship with the government, with the different ministries, it was challenging. So we had to build it from scratch, right? So I think what was really important for us with this is that we actually informed them from the very beginning that we want to do the study. We actually sit down with them and ask about the priorities that they have with the ongoing war. And I think that was very sorry, I think it was very important because my colleagues are shouting here. I think it was very important because, well, first of all, it also gives the like you have the responsibility of doing something, and the ministry, actually the Ministry of Health and the different public health institutions, because we are very lucky to also not working only with the ministry but also with the health institutions, they understood from the very beginning the importance of this project. And maybe I will just add that from it is also important and maybe worth not only to include like one body, so for example Ministry of Health in this case, but also other institutions, because maybe sometimes they have more flexibility to do the project, maybe they have more capacity, and they have dedicated people who can work with you from the very beginning. So this is my take on this. Thanks.
Thank you so much. Yeah, Rupa?
So Kash, very quickly responding on this, I think the game changer for Turkey has been right from the beginning when the earthquake happened. This was an issue that even the government was grappling with. The NGOs, INGOs, everyone in the field, whoever was visiting the site, were grappling with this issue. And I think that was a game changer. Why? Because there was a readiness and receptiveness towards something like this. And this particular initiative, when was undertaken and this results was shared, there was an immediate, agreement from the government to kind of scale it up across all the provinces and not just limited to the 11 provinces which were affected by earthquakes. So the 75,000 workers who got trained were from all the 81 provinces. The other thing, which was, of course, a part of the collaboration work within UNICEF, to have your sectoral colleagues work with you together on this, because a lot of time for SBC, we are not the front face with the ministries and governments. So working in collaboration with different sectors really helps you build that kind of, leverage with ministries and government. The other thing, which like Agam mentioned, I think the work has been extensive with health sector, and therefore the readiness and receptiveness you see within the health sector increasing over a period of time in terms of seeing what innovative methods, nudges, etc. would work. We do need to kind of build those inroads for other ministries like family and social welfare, for other related areas like education, etc., which may not be as easy a pathway for us, because the amount of work that globally we've been doing with health vis-a-vis other sectors maybe much more needs to be worked around. So I think that has been essentially our approach and ways to address this aspect.
Super interesting. Thank you so much. I think maybe we can squeeze in one more question. If no one else has any, then I guess one for Amos. Like, how did you, so moving away from evaluation, but general behavioral science, like how did you first sell the idea to your government counterparts or even your country office, right? Being the SBC person in the country office, having to sell this new approach, this new concept, like what were some challenges, or were there any challenges at all? And then with the government counterparts, like what was your approach there?
Yeah, I think the readiness and the receptiveness that my colleague talked about earlier was also ripe in Cambodia, because after COVID-19, I think there was an appetite for some of these new approaches, because we had piloted some of these approaches in COVID-19, and the government had seen some of the early results for this kind of behavioral design interventions. So that gave us an entry point. But obviously, beyond that, the process of doing research, iterating, and testing, a lot of government partners are not used to that. They want to have the messages, give me the posters, give me the messages, I go and implement the intervention. So there's a lot of, obviously, that's why we focus on a lot of capacity building, training, doing things together for them to appreciate the process, which that helped a lot to really bring them on board and work with them along the way. But also the other component was that we were embedding in an ongoing program, and we are telling government, okay, as you implemented the traditional parenting sessions for government, as we are embedding a nudge component, let's try this additional approach and see how much value it's going to add. So it looked, they were receptive because it's already complementing an existing government program.
Amazing. Thank you so much. Faisal, with your previous experience in Pakistan country office, how was it engaging with the government and selling this idea and concept?
So as I probably indicated in my talk as well, there's a certain level of superficial agreement, but I think the real problem is that government institutions are not value producing. They really can't, even if you invest design and money into what they accept to work with us on, they're unable to produce value out of it. I think that's a significant problem, and so I often think of it as the first step in interacting with them. The project, I think the changes that they need to commit to are much longer, perhaps generational. And I don't see that happening, unfortunately. And I can say that confidently for other countries as well in which I've worked. It's not just Pakistan. So again, slightly pessimistic view, but I just wanted to bring that up because that is a sort of a constraint on programming it with UN programming. And so we need to recognize that. Thank you.
No, and I think that's an absolute valid point. But I mean that creates the opportunity for us to figure out how we do that, right? And then that's what we're doing as well. Like a perfect example is working with AGA at the moment. We're working with the Polish government to try and establish behavioral science units. So then we can start to improve the capacity for governments to kind of do this themselves and to accept the value in some of these activities. So no, thank you very much for that response. Okay. Any last statements, comments from our speakers? No. Okay. Well, thank you so much for coming and sharing your work. It's always super interesting to see. Yeah, and thank you everyone else for attending. We will send the recording, like if you've registered and you're on the email list, then I'll try and send an email with the link to the recording as well as everyone's presentations. Anything else, please reach out to all of us for any other further questions. Thank you so much. Have a lovely day. Oh, wait, we had it. Was that Hamid?
Thank you, Kash, and thanks, colleagues.
Thank you.
Thank you very much.
Thank you. See you later. Bye.
Bye.
Bye-bye.